We do have a plan to make up some time, but we need your cooperation. If folks like Dina Gray Hughes can help us get back on track and target, that would be great. So we are going to do exactly what we promised, and that is allow for some questions for the first set of our panelists here. We're going to shorten how many questions that we take. So if you want to be in queue, please raise your tank card. We'll try to move in rapid succession.
Okay, 30 more seconds left. We're going to jump right into it. Everybody, please take your seats. $20 seconds. Are we good? Okay. Go ahead. Cool. Okay, so thank you again to our panelists and our guests. Thank you again to our PACHA members who are here in our community, who is all here. I see that we do have one for sure question. As you all know, our procedure is to raise your name cards up so that we can know who to call on and put you in the queue for Q&A. I believe that Rep. Jones had some questions she wanted to lead with, open up with for Doctor? No? Yeah? Well, let me say this first as we get into things and we talk about testing in Texas. I know that as you all can see, the landscape of healthcare and access and our politics are, I can't say that word. It's bad. It's not as good as what we would hope it would be as some of our more progressive states. I even had one of my colleagues here talk about how much worse we are than Florida, which says a lot about us here in Texas, but I'm appreciative of the work that we're doing to try to move past that. And you talked about testing, Rep. Jones, and you talked about your experience of getting diagnosed with HIV and your experience going into an emergency room, which is very similar to mine. I can remember 10 years ago going into the ER, throwing up blood. I'm really sick, felt like I had the flu. I told doctors this. I told them that I'm a young Black gay man in college, freshman, all these things. Just got back from spring break, tell them everything. And they're like, oh, we're going to test you for the flu. That's it. Flu test came back negative. Oh, we just must have detected it early. We got you early. We're going to give you some medicine. They tested for nothing else. It wasn't until 2 months later I decided that I pushed to get an HIV test to figure out that that's what it actually was. But you all have made so many strides in the state legislature as far as testing initiatives and pushing for new bills. What did you all do differently this time around in the state legislature, Lindsay and Rep. Jones and Ms. Sophia? Feel free to weigh in on this. What was done differently this time to get your colleagues to work across the aisle and help push these bills towards the right direction and to be heard by your colleagues?
Absolutely. Well, prior to this legislative session, I was a participant at convenings like AIDS Watch and, Texas, convening HIV Advocacy Day. And so you just didn't see the same prioritization of the bills that I had to put into it. So one, these two were not just bills on my roster, they were my priority bills. Also, the need to build relationships with both sides of the aisle and identify myself not only as a member, but also as a person living with HIV who this very much so impacts. And for so many members, they never engage with the person living with HIV that could have this conversation with them at a colleague level. And so it was really, the thing that we do always is, tell our story and be authentic to the work that we're doing. And that was actually, a lot of the heavy lift. I will also say it had a lot to do with karaoke too.
I'm just about to say
that. So
yeah, explain what do you mean? What's
karaoke? So anyone who knows me I love a good karaoke number. And so part of what my team did actually during the first part of the legislative session in Texas, you can't pass anything or put anything forward for the first 60 days of the legislative session. And so during that 60 days, my team would host an event called the Capitol Karaoke Crew. And we thought it was just going to be, a small, little thing, but it actually turned into an event that when we had our last one at the end of session, over 200 people showed up. And so at the beginning of that, with a live band, at the beginning of that, this was important because this is where I met a lot of my Republican colleagues, because what I didn't want to do, based on my engagement in the Texas legislature prior to being elected, I didn't want my first introduction to a lot of these individuals to be on the battlefield, the House floor. And so this environment, totally changed how they were able to get to know me outside of just, one of the first, Black LGBTQ people and, the person living with HIV. They got to know Benton, and we got to really know each other. And that was huge because it was oftentimes when FLAC was taking place, I would be reminded of those nights at karaoke, and really just the importance of building relationships, because that doesn't happen in electoral politics, whether we talk about in the state of Texas or even nationally right now.
You're absolutely right. And if I could just name some names, I'm going to be messy right here. That's exactly right. That environment was amazing. And then the Texas Monthly decided to write an article about it and how strange it was that Republicans and Democrats were having a good time together. And then all of a sudden it scared away all the Republicans. So thank you, Texas Monthly, for making things very difficult for us this legislative session.
Right. And it didn't scare them all away.
Yeah.
A lot of people were a little spooked, but also a lot of people doubled down to say, like, this isn't right. Like, we actually should, like, what did we do wrong? And it actually kind of doubled down support for pieces of that legislation. So, yeah.
Cool. Thank you so much for that. And for those of you all who don't know about the state legislature sessions, they only meet 180 days out of every 2 years. And that's out of 4 years? 140, sorry, my bad. Only 140 days out of every 2 years. And so the even year numbers, they don't meet at all unless the governor calls for a special session, which is usually for the bills that the Republicans want to see passed. But other than that, that's the only time that we have to actually get things done at the state level. There are 5 name cards that I see raised. That is all that we are going to take. So if your name card is raised, yours will be answered. If it is not, I'm sorry, but we don't have time to do those right now. So I'm going to go in the order in which that I have saw name cards go up, and we're going to start off with Dr. Leo Moore.
Thank you. First, I just want to say thank you to the panel. This was excellent level setting for me and really helpful. Also wanted to thank you all for all of your efforts, hearing about the 140 bills, anti-LGBT bills that you mentioned, and having to be there and to advocate every day. Like, it was just really, inspiring for me. I also wanted to ask Dr. Giordano regarding HIV testing. Has there been any memos sent to the Texas Medical Branch, ways to get the word out to providers regarding HIV and STD testing? So I know that we're doing the work regarding getting a bill passed, but what's the work that we're doing as far as educating our providers to go ahead and be offering that HIV test? Thank you.
So at the local level, it is part of our curriculum at Baylor College of Medicine, and as I showed, there's a lot of work going on around the Project ECHO model with the AETC to try to disseminate the information on testing and Rapid Start. They kind of link together through our AETC. Operating here in the state of Texas, you choose your battles wisely. And every time you raise a flag, you run the risk of hurting yourself. Do you stand up against the machine gun fire, or do you lay low and then decide to try to snipe a few things or operate under the radar? That's a constant battle for all of us. We're always trying to make those decisions. And so when we rolled out our routine testing program in Harris Health, we had our lawyers review it. We got the administration on board, we got the health system on board, and we rolled it out. We chose to not make a huge deal out of the success of that program, other than to federal partners, because of the environment. I was asked to testify to the House Health, one of the health committees for the House here at the School of Public Health when we first rolled that out. And they were warm, and then they asked the political questions, like, isn't that, can you do this? Why are you doing this? And you just have to choose your battles wisely here. And so we are educating providers, clearly, and medical students, but to try to get a state action on it, we'll leave that to the professionals.
Thank you. Carol Treston.
Thank you. Congratulations, Benton. It's so nice to see you in that spot. I want to, first of all, Dr. Giordano, thank you for that really exquisite slide on equity and funding and the difference in Medicaid expansion states and what that means. That was really powerful, and I think we need to use that more often in other settings. So thank you for that. But I wanted to also make a comment and then a question on how can communities support the efforts that are happening at the State House. And in particular, shout out to PWN and the incredible work that they do, but also to bring attention to the potential of nurses in state-based advocacy, knowing that, you know, for the 20th something year in a row, the Gallup poll has voted nurses as the most trusted source of health information. And we at ANAC leverage that into political advocacy. So thinking about partnering with Texas nurses and in particular members of our organization to also do some of that advocacy at the State House and really, you know, turn that trust in nurses into trusted advocacy as well. So that's an offer I'm putting forward. And I know that my colleagues from the ANAC Houston chapter support that as well. And my question, though, is how do you maintain your well-being in this incredible atmosphere? 141 bills is a lot of hate. And how do you maintain your well-being in this field?
I think there are two things. One, cabin trips. And two, one thing that has really helped being in this first legislative session is the support of the HIV community. This community was where I cut my teeth. This community is really what gave me the strength as a person born and raised in the same district I represent, take a trip to DC for 10 years and be able to come back and continue that work. And throughout those experiences, the good, the bad, the ugly, it really gave me the strength to be able to understand how important this work is and how we really have to get out there and have our voices heard in a very different way. So often when we had these conversations earlier in my career about the issues that were happening in Texas, it was blamed on the elected officials. It was blamed on the health department. And so I literally had one of my mentors and dear friends, Cornelius Baker, tell me, well, honey, what are you going to do about it? And so that was the charge, to be able to come back and start, you know, doing this. And I will say that part of the elected piece was a little bit of a break from the HIV work, which is really the hard stuff. And because coming back, it wasn't just about being elected, it was the problems that I saw as a person living with HIV, as a person running an organization, serving people living with HIV, and now a national commitment to end HIV by 2030, and really understanding in a place like Dallas that wasn't happening, and understanding that shortly after this charge was made. And so that led me to, you know, being the chair of our HIV task force, getting involved with fast track cities, and ultimately getting elected, and still realizing how much work needed to be done. And so just coming back to the answer to your question, throughout all of those challenges, it has been the HIV community that has sustained that, and people who have understood the challenges of working with our government, you know, back to the very early days of this epidemic, where HIV advocates were charging, you know, our federal departments to make sure that our voices were heard and that people living with HIV were served in an equitable and fair manner.
Thank you. Next up, we're going to let Jesse go into our other three members. If you guys can, please just write your questions down. After we let our other panelists go, we will come back and allow you to ask those questions, okay? Jesse.
Thank you so much. And this is a big shout out from AIDS United to our members, for Lindsay and Legacy, who's a member of our Public Policy Council, so is Equality Federation. But I particularly want to say, Fenton, that last year we celebrated the 40th anniversary of the Denver Principles, meaningful involvement of people living with HIV, and so rarely do we ever have meaningful involvement of people living with HIV in any legislative body. So congratulations to you. My question is, and I asked this of the director of DASH, the Division of Adolescent and Sexual Health at the CDC last week, Is there a carrot or a stick that you would like to see the federal government offer through cooperative agreements or in any other way, particularly cooperative agreements from both CDC and HRSA, that could be either a carrot or a stick for eliminating criminalization laws at the state level or for advancing eligibility for Medicaid in your state? Is there a carrot or a stick that you would like to, that you wish were being offered from the federal government?
Absolutely. Well, first and foremost, there's a huge disconnect between the federal and the state and local efforts to end the HIV epidemic. I had the honor of both serving as the chair of the Dallas HIV Task Force at the same time that I was a member of the CHAC. And what I realized during that process is that I would come to these meetings and be told one thing about the process and come to the reality of my community, not being served. And the biggest weapon that was used by government, entities was the RFPs that were created. And so I just can't stress the importance of making sure that there is language that addresses those things, because if it is absent, that gives those entities the ability to possibly do or not do the things that we should be doing. And so if we're already communicating about the needs to address those things at the federal level, I ask that federal entities make sure that in their RFPs, it makes those things clear, because one of the largest challenges within the implementation of the EHE funding was getting a clear definition of what does community engagement really look like, and what is the obligation of local health departments to fund local organizations and bring non-traditional voices to the table and support smaller organizations, in which you see so many individuals at the table are now running organizations. And so that RFP is so important, in making sure that that language to address those things are part of the mandate.
Cool. Okay, thank you so much for those questions. And thank you again to our guests. Lindsay, you mentioned something earlier about testing and about how, outside of the Houston systems, we're not too sure about how many people are actually intentionally testing. Just want you to know that in Beaumont, we are testing. The Triangle Area Network, Baptist, and your legacy colleagues are actively testing folks for HIV in Beaumont, Texas. So I'm going to turn it over to Ms. Marlene McNeese to take over the next portion of our panel.
Thank you, DeAndre. And this conversation simply continues. So I do have you, Daryl, Paul, Marvell in queue for questions. So we are not going to miss you. I just really wanted to thank and congratulate again our colleagues on the first half of this panel. But I loved what you ended with just now, Vincent, about the efforts that could be done all the way down to the local issuance of an RFP that can be supportive and transformative, dare I say, in community. I see we do have representation from Daniel Montoya in the room with Gilead, who supports a good number of projects centered around their HIV focus program that really are advocating and pushing for syndemic approaches. And so syndemic approaches to routine screening, we started our day talking about the overlapping syndemics of STIs as well as HIV. So in our next Houston RFP, for those of you with open ears and live and reside and do work in the city of Houston, we are adopting models and approaches that were born out of the Gilead Focus Project about how can we support the implementation of routine screenings in this high volume departments and clinical centers, whereby we are being able to capture more in spite of there not being a law. So there are things that I think we can take into account. So I really appreciate all of the conversation and you guys lifting up, again, practical ways, practical solutions. And for members around the table, if there are other thoughts that you have about ways in which Texas might be able to benefit in unique ways, there are strategies and approaches that have to be different here. And I'm hoping that you get a good sense of that. But I do want to welcome your feedback and your thoughts. As you can see, we are a committed group. We work together all the time. So I have the pleasure of facilitating a conversation with our second half of the panel. Dr. Giordano said it perfectly. I think we are closely aligned in terms of partnership and comradeship. And I think that's because we have to be. in very hostile waters, we are all making sure that we keep our heads above. And so it is difficult work that we do. And so almost all of the next 4 people you will hear from, we spent years doing the work together. So what I hope to do in this next half of the conversation is allow them to introduce a little bit of themselves and the work that they do. They're just going to have some brief opening remarks and comments, and then we will continue on with the questions and conversations. With this approach, we had hoped to create more space for you all around the table to be able to ask those questions. And then we should be able to break close to lunch, maybe slightly after, maybe 12:15-ish, but we're not too far off track. So just wanted to make that remark. So it is my pleasure to introduce to you all my colleagues throughout the state of Texas. I will begin with Hope Adams. She is the Ending the HIV Epidemic Program Manager for Tarrant County, for those of you who don't know, in the Fort Worth area of our state. So Hope, introduce yourself.
Thank you very much. I use she, her pronouns. I've been the EHE Program Manager for about 2.5 years now. Before that, I was a health educator teaching about HIV stigma, the importance of equity. I taught about institutionalized racism, a whole bunch of things that play into HIV stigma. Our current program, we're small and mighty. We have 4 people total. I have a social worker who helps people in a status neutral way to overcome barriers to obtaining HIV-related care, whether it's PrEP, whether it's getting onto ART, that kind of thing. And he helps overcome barriers such as housing, underemployment, underinsurance, uninsured, any kind of social economic barrier that one might experience, he can hopefully help them overcome, so then they can focus on being either preventing HIV or taking care of their HIV. I know people who are experiencing homelessness, that's not their priority. And so we want to help them where they can focus on their health as opposed to where am I going to stay tonight. I have an epidemiology specialist who is working our data to care list for the county. He specializes in connecting with people. He's a great people person. He's having great success getting people back into care. He works with our community service aide who is bilingual in Spanish, and she works with the people who are Spanish speaking who need to be linked to care. And we are working hopefully with Dallas County soon to do warm transfers of people who might be out of jurisdiction. But we can say, hey, you know what? I know this person at Dallas County. I know you live there now. Let me get you connected with them instead of, oh, you're out of jurisdiction. Whatever. We're hopefully going to come up with a program where we're not doing that anymore, at least with Dallas County and Denton County to start off with. Denton County is to our north. They're a pretty rural area. I have a community service aide. She does all things EHE. She's my go-to for, we do event planning. She is our connection with the Latinx community. She helps me out with just anything and everything I might need. We're really excited. We've implemented some fun stuff. And what I like about EHE as opposed to other programs is that if it's not working, we can pivot really quickly. So if we're not reaching our target populations, let's try something else. So I really like that. I have some great plans in the works for 24 and 25. So I'm really excited about that.
Thank you. Next up, I'll invite Miranda Grant, EHE Program Manager at Dallas County Health and Human Services.
Thank you. Thank you all so much. And I'd like to say, welcome to Texas. So just a few high-level things. People talk about how are you going to end the HIV epidemic. We've had so many fantastic comments, and thank you all for just shedding some light on the unique opportunities that we have here in the state and locally in Dallas, where I'm from. I'm born and raised in Dallas. You asked, how do you sometimes cope with the challenges? And it is our home, right? And so when you experience challenges in your home, then you show up. So with that, I do want to say a special thank you to our community members, our groups, our advocates. When we look at how we will end the HIV epidemic in Dallas and in Texas, it is going to be through those partnerships. It's going to be through community and through collaboration. And I see a couple of them over there. Antoine, smile, woo woo, Nathaniel. We have, as Benton mentioned, one of our founding members for the HIV task force. We're really focused, especially after COVID, on reestablishing those relationships, right? We have silos in Dallas. We talked about even local relationships are not for the faint of heart, right? So we've really wanted to establish a space where folks can come together in person. We also have fast track counties, which is more of our implementation arm of our integrated plan in Dallas. There's so many really, really exciting programs and services I'd love to get into for Dallas, but just at a very high level, we are a large jurisdiction. We have about 2.6 million people, and we're really, really excited to be here, to learn more, and to answer questions. Thank you.
And next we have Ms. Dawn Jenkins. She's the Director of HIV Services at Harris Health System.
Good afternoon, everyone. I am going to be brief. I'm from New York, and a New York minute is 30 seconds. Yeah. So, just to run it down, I do not have to repeat anything because we have a wonderful room of caring providers, and we all do the same, if not similar things. As the Director of HIV Services at Thomas Street Health Center, I'm just going to give you a few caveats in terms of how it works for us. We have about 5,600 people living with HIV. I am proud to say that we have an 88% viral load suppression rate. Right. That's 88%. I'm going to tell you how we did it. Dr. G is also from New York. I see Dr. Flash, Brooklyn in the house. Yeah, you know what we do? We just do it. Yeah. We just do it. Before there was EHE funding, Dr. G had led the charge to, we need to get them on medicine right away. How are we going to afford it? I don't know, but we're just going to do it. And we put some strategies together. And then we said, okay, it's not funded. Maybe we give them 7 pills or 5 pills until we can get them registered for ADAP. And whatever we went over, we made a call to Ryan White. Hey, Cameron, you got any extra money? So whatever wasn't spent, she said, okay, you can pay for the medications. So that's just to say, with all of the innovative ideas that we have, I'm absolutely impressed. Texas, y'all are doing it. You're saying you don't have Medicaid expansion, but as Dr. G's slide shows, I did this in New York City for 16 years, and I came here, and I was like, dang, they ain't got no money, no Medicaid expansion, and you are doing it. So we can certainly do more, but it's about you got the eggs, you got the milk, I got the meal. Let's make some cornbread. And then we figure out how to do it. I want to give a shout out to Dr. G, was our medical director for 18 years. He raised up Dr. Serpa, Dr. Patel, Dr. Flash, and a wonderful community of providers. We got 2 at Thomas Street, 2 schools. So some of our clients go, this is the county. I said, but you got UT, you have Baylor, those are your physicians. There's tons of research that happens. And for all of you in your prospective health centers, I do know that Ryan White, if there is a specialty service, right? Harris Health is more than just Thomas Street. There's cardiology, there's all kinds of other services, because our people living with HIV and AIDS might have uncontrolled diabetes or out of control hypertension. Ryan White will pay for those services that you might not have at Harris Health. So Harris Health is a huge hospital system with many medical services, and Thomas Street, as a medical home model, we take care of every need, every single need. One last thing, behavioral health. There's a population living with HIV that might not always get to their psych appointments, may show up to your clinics and show out. And what do we do with that population? Do we just leave them there? It's a challenge. So we developed this thing called the Red Carpet Program, coming soon to a center near you. We are going to teach that for those particular clients that can't really navigate too well, may act out. We partner them with somebody who they may say, okay, I'm gonna act out with you, but not with you. and you escort us through those appointments. We know what their triggers are, and it's everybody that works with these individuals. It's the security officer, the cook in the cafeteria. It is everybody because it is a community approach. So thank you very much, and I am just truly blessed to be here in Texas.
Yeah.
Ooh, child, it's hot.
Thanks for looking up. And the last gentleman, he and I have been tied at the hip at the City of Houston Health Department. I've been without an EHE coordinator for a while. And we have a Harris County Health Department. For those of you who don't know, we have 2 local health departments. And so the idea that Jason Black has been leading those efforts over at the County Health Department, he and I are on tour together almost all the time. So Jason, go ahead and introduce yourself.
Yeah, thank you, Marlene. And so my job is made easy because I get to partner with colleagues such as Marlene and then be able to provide resources to organizations such as Thomas Street, who are doing amazing work. As Marlene said, here on a local level, one of the uniqueness about us is that our funding is split between health departments. And so when we talk about the pillars and across those pillars, her team leads those first 2 pillars for us. And then I lead the second one, which is our treat pillar. And so we focus on people living with HIV and what we can do and strategies that we can do around ending the epidemic around those activities for people living with HIV. And so some of those activities that we have funded over these last 4 years have been, of course, Rapid Start and test and treat models. We have looked at how we address barriers around transportation. We have looked at, for sure, housing as healthcare. And so we, for sure, have piloted projects around housing and how we can address some of those barriers around that our population sees around housing. We also have worked, as you've seen from Dr. Giordano's slide, with our partners at AETC around how we do implementation of these strategies, how we empower our workforce to be able to stand up around this strategy around ending the epidemic. And then myself and Marlene, we are joined at the hip around what do we do around our response pillar. And then on a local level, we have tried to be innovative in leading the charge around quality of life and have adapted that pillar as one of our official pillars. And so we jointly lead work around how do we address quality of life for people living with HIV here on a local level. And so, yeah, that's some of the work that we're doing on a local level, and we'll talk more about that.
So as you can see, we do have some amazing leadership in the state of Texas involved in this work. The idea that Dr. Giordano started with level setting about where we are with the data around the epidemic, and we're fairly holding steady is the takeaway. And I think in a state like ours, that is success. But there's a hell of a lot more that needs to be done and can be done. And so the creativity, the innovation that sort of is born by these partnerships is what is making it happen. And I think that's what will help us to achieve success. I do want to spend the rest of our moments and minutes together combing through conversation. And so I said, I already have Daryl, Paul, and Marvell in queue, and then I'll take Mackenzie, Rania, and Dr. Tukes after that.
Really appreciated the presentations, and this actually picks up where Jesse was going. Can you provide me, because maybe I'm missing a key element, tell me what you think are top 3 amongst all of you, just not 3 each. What are the top 3 things that you want PACHA to know to bring back to its advisory role? Because I've appreciated the detail at the Texas level. Some of this you're going to have to rely on Vinton and others to fix for you. But what do we need to know for PACHA level to bring back as a national agenda item?
I think I'll go. So kind of to Tori's point when they were giving their update, I think that this funding came at a unique time. And I think that if you guys could give some level of guidance, especially on a national level, of how we kind of reintroduce what ending the HIV epidemic means, right? That then for us on a local level as funders could utilize as guidance of what that means, what types of projects we can fund, what types of activities we can fund. Because similar to what Dr. Giordano said, you know, for us on a local level, what one would say is innovative may not be innovative on a national level, but is it innovative and meaningful to what it means to end the epidemic for us? And for me, working with my national colleagues, that's been one of the challenges, is that they keep on saying, oh, that needs to be innovative, right? But for me to supplement what it means to meet the needs of some of our runway Part A funding is innovative for us.
And if I can add a concrete example as well, centered around what happened when we had a large insurer who had a policy change without much forewarning that they would move to only covering multi-tablet regimens. They would no longer cover single tablet regimens for people living with HIV. It was because of that policy change that created an obvious and immediate and emergent need. What occurred is a conversation between Harris Health System, Don, Jason, and others who said, what can we do? Jason was able to, on the fly, create a new way of using their EHE funds to be able to support some of those activities to sustain people living with HIV on the regimens that made sense for them. That's a practical example of the flexibility that's required and some explicit language or allowances. I think much of what the PACHA table can do centers around guidance and recommendations, but it's not just to the secretary and just to our federal colleagues. Much of what we put out in the universe can be utilized at the local level to say, hey, here's what the experts are saying are our best practices and evidence-based. So I do think we should not lose sight of that being our role as well. We do give a lot of information up to the administration, but it also helps when we disseminate messages out to community. I hope that gives you a concrete example.
Can I give,
let me just, Marlene, I agree, and that's exactly the kind I want to get to. This dissemination of content based on local can be part of the agenda, and that's what I really appreciated the level setting and the contextualization. It's rich, and especially as we go around the country, and it's an and not a but. It really is critical that when we have the globe is watching, that we adhere to what, as much of what Dr. G was saying earlier, we have to make sure we're sticking within our mission and delivering on that so that you know exactly why.
That's right. That's right.
I just want to provide a context or recommendation to you all, Jason, and everybody else here, is to let us know or send in recommendations of what's working at those local levels so that we can see and measure up with how that can work for the nation, and seeing what works for, what works for Texas might not work over in other states, but it's important to see what's been innovative and what works here. How have you gotten to an 86%, I think, 88%, yes, right, viral suppression rate. So it's important for us to know those things, what works here, so that we can make those recommendations going forward at a national level.
Can I make a couple quick comments? Make it easier to stay on Medicaid. Make it easier to stay on Ryan White. The state puts up barriers. If the feds could somehow make those barriers disappear, that would be great. Make it harder to kick people off Medicaid, because the state does a great job of reducing their expenses by kicking people off Medicaid. So those are federal policies that could help. And then I will say again, equality is not equity. So make sure that the federal formulas are not about, if we want to end the epidemic, it's not about equal funding per person with HIV. It's about giving more funding to places that need the funding.
Marlene, or Matt, may I respond quickly?
Yeah, quickly.
Yes, I just want to say it is, your point is so well taken, and it goes to redefining the guidance for EHE. There is a fundamental question: do we really want to end it? And that is not just an academic question. And I saw the chills go through, and I think again, you know exactly what I'm talking about. Some things talk and some things walk. And you know me from way back. I'm gonna stay clean, but I'm gonna push. That I'm not convinced that at this moment in time that our health apparatus writ large is truly committed to ending the epidemic.
That means a lot of money. Rep. Jones had one comment.
Yeah, we'll take Benton and then we'll go on to Paul and Marvell.
Okay.
One thing I want to briefly say is something that is needed is the data from a cost perspective. The two issues that I had with my two HIV bills were met with the barrier of one, what models have routine testing worked in other states, and what is the data that supports that? And two, the conversation around the expansion of Medicaid is argued with the conversation around what does this mean if all these people now have access to health care? We already have a shortage of doctors. We already have a shortage of nurses. We can't do this. So any data nationally that can be provided to make those cases in the state would be extremely helpful.
I want to start by just saying mad respect to all of the folks who are working in Texas to end the epidemic. I have no idea how you do it. And I want to really spend that. I want you to know that. I want you to know when you have 100 and something bills that are coming for your community that it is shit. And I have such respect for that. But I wanted to take my privilege as one of the oldest queens in the room to say to Representative Venton, we are so proud of you. We are so proud of you. For those of you who don't know, we've watched him grow up. We have literally watched you grow up. And to hear today about how you are taking all of that and pushing real legislation, do you know how powerful that is? That is, thank you. Thank you so much. Yeah, we're both gonna, I'm an old queen, I can cry at anything, please. But it is an extension of the work that I don't think we ever thought was really gonna happen. You know, it was all about ending the epidemic and the disease and not about building the new leaders and about building people who are stepping to the plate. Yesterday, we had the opportunity to visit these 3 amazing organizations. And I know that many of them are here. And I want to tell you what a privilege it was to see your work and to see what you are doing with the HIV funding. You know, I don't think we always understand because we want to look at how many fewer cases. We want to look at what's the viral load. What we don't see sometimes is the community that we're building, the leaders that we are building, the agencies that are coming up from nothing, you know, that really have nothing and are doing God's work. They are doing God's work. And so I just want to thank all of you and let you know how that we see you, that we absolutely see you.
Thank you. Marvell?
Well, thank you for that, Paul. My comment is also to you, State Representative Jones. It's first a comment and then a question for you. The first comment is relating to a comment that you stated when you opened up, that you have a lot of mentors in this room. And so I didn't want you to leave this space not realizing that you too have been a mentor to so many of us. It was through your work with the Young Black Gay Men's Leadership Initiative in 2012 that I got to meet you. And I sit here because you exist. So I wanted to say thank you for that. The second piece is, because I have worked with you, I know that you use precision with your words. I know your dedication and I know your commitment. And you stated in your introduction that you do not believe that we will end HIV by 2030. It is a sentiment that I agree with, but if you could expound on that a little bit. I know you talked about the RFP, the language in the RFP, the cost analysis, but are there any other recommendations that you can provide as an elected official that will at least get us somewhere in 2030-ish?
Absolutely. Well, yeah, thank y'all. Y'all about to make me. I think there's a couple of things. I say I don't believe it because I think a lot of entities are saying what they need to say to get their funding. When it comes to the coordination and mobilization of people living with HIV, when it comes to the monitoring of that progress, you tell me in Texas or any of these other EHE jurisdictions where you can find a plan that is being monitored in real time towards success, I'll give you my next paycheck. It's not happening. And so we can't even tell where we are going when it comes to ending this epidemic. When it comes to addressing issues such as discrimination, the COVID pandemic and its impact that it's had on the disruption of care, there are some additional factors that have not been considered into that formulary. And so I think that there needs to be a revisioning of what this initiative is and how we are really centering efforts to end the HIV/AIDS epidemic. I just don't think that we're there yet. We're doing a lot of things, but oftentimes it's not coordinated in not only on the local level, it's not coordinated on the state level, and it damn sure isn't coordinated with all of the 48 jurisdictions. And the conversation, the people that we continue to focus on are just the healthcare providers, when we have a whole community that supports the end of ending the HIV epidemic, and we don't even prepare them to be at the table. When I first started this work, there was the African American HIV/AIDS University. The CDC had a capacity building program for mid-level managers. There were all these things that really worked to build capacity. None of that exists. So I'm not there with this that we're going to do this by 2030.
Thank you. And I wanted to say it was you that built my capacity, so I appreciate that.
Thank you. I'm really going to need y'all to stop before I lose it up here. We have 4 more in queue, and I think we'll have these 4 be our last questions and comments before we break for lunch. I have Mackenzie, Rania, again, Dr. Tukes, and Guillermo will close us out.
Wonderful. Thank you. And it's awesome to see family reunions happen. Appreciate all of you guys being here. My question is a bit more mathematical and financial. For each of the groups who are leading the county's responses, I'm curious by how much your HIV budgets increased as a result of the EHE funding.
I honestly do not know. I know what my particular program is funded for, and that would be in addition to whatever the health department gets. And it has not changed since I know of. I get about $637,000 a year to do my whole program. So, yeah.
For the county?
For the county, yeah. Yeah. So we have 2.3 million people in the county. I had to Google that last night. Like I said, we're small but mighty. We're really trying to make community connections so they can help us do the work, because obviously 4 people can't do a whole lot in terms of making a dent. I would love some evaluation. I want to do a program evaluation, even though our activities just got started live in 21. I still want to see that we're going somewhere with it. NASDAT is doing an evaluation summit in May, which I'm going to, which I'm excited. So I agree with Mr. Jones that we need to know where we're going to see if we're actually getting anywhere. But yeah, our funding is small, but we're mighty.
For Dallas, we're about $5 million for both the CDC and HRSA funds, and that fluctuates a little bit year to year. But for comparison, it's about 31 on the Ryan White side.
And I'm sorry. Yeah.
Yeah, it's about 5 million.
Cool. And do you know what it was prior to EHE?
So our Ryan White dollars if we're looking at the prevention side, no.
And as I can, Marlene probably can speak to where our prevention dollars look like for care. We get about $25 million from Line Right Part A, and then we get roughly, this past year has been our highest funded year for EHE, and we got about $4.5 million.
I don't have the exact figures in front of me, but I want to say we typically beg for it all. I think we might have had somewhere around close to $1 million, but with the changes in the availability to fund the single tab regimens, we continuously go back and ask, can you give us more money to fund this? Whatever the need is, we just continuously go back and ask, and we ask for that overage or underspent. So if you're not spending, we are going to ask for that, just because we serve the largest percentage of people living with HIV in Harris County and the extended metropolitan areas.
Yeah, totally. And I appreciate the patchwork solutions, whatever it takes to get the job done. A $4 million increase based on, say, you were around $25 million prior. Doesn't seem like a 20% increase in federal funding via the EHE initiative would be sufficient to end an epidemic that's been going on for 40 years. So just wanted to note that as we continue to, well, hopefully drive to end the HIV epidemic and give our carpenters all the tools they need in order to build that response. So thank you.
I just want to add to that, particularly for us, like as a county, right? We look at that county stretching over 1,700 square miles, right? And then that's serving multiple counties under that funding. So, yeah, that's not.
And as PACHA has heard routinely from community, the idea that every level of funding funnel creates additional challenges and limiting the resources that actually land for on-the-ground implementation. So I think the takeaway, and we've heard it from community time and time again, the more direct support, the better. Whether that's direct to cities and counties, direct to community-based organizations, etc. Direct funding helps. Every time you pass through an additional level, some gets peeled away. Hope, go ahead with the roundup and we'll go right to Ron.
I wanted to speak to the different levels of funding. Our program is prevention only. We have a separate HRSA-funded EHE in our county. I don't know if it's a state requirement, but the CDC money goes to our state, and then they decide how much each jurisdiction gets. And so when I'm asking permission to do an innovative intervention, I have to ask the state if they allow me to do something like that. And oftentimes the CDC is less restrictive. So the CDC says, yeah, you can try that, but the state goes, mm. So to the funneling effect, and the state gets funding for administrating the program. So just to speak to that.
Thank you. So Houston is the only directly funded EHE jurisdiction in Texas. We will go to Rania.
Thank you guys so much. As a lifelong Angelino, and I've been to Texas many times, but y'all are really showing out. I'm like, maybe I can live here too, because this is, you guys are giving me some good energy, and I appreciate that very much. You know, my question was really around, I think I love this panel, and I love having all these EHE administrators in one space. I do a lot of work with EHE funded jurisdictions, and the innovation, to me, depends very heavily on the administrator in the jurisdiction, right? So if they can be innovative of how they want to use that money, you see the impact and the way it flows change pretty dramatically. And so my question I had to you all was, you know, if there's one thing that you could ask of the federal government around a change you would want to make to EHE, what would that be? Jason, you gave that a bit to us. So I love this idea of reintroducing EHE to communities. We are now at the halfway mark of what was supposed to be our 10-year effort to end HIV. And so I love the concept of a reintroduction. So I'm thinking about PACHA, what might that look like? I also hear from Hope from you around evaluation. When EHE first came out, there wasn't a heavy emphasis. One of the pillars was never around evaluation. And so maybe that's something that goes in here, but I'd like to see if there's anything else that you guys can add. If there's one thing that you said, hey, please add this, include this in EHE, that would make your job easier, more impactful, what would it be?
Yeah, I would say to also continue to support these convenings and spaces, because EHE is so unique. It's different and it looks different in every single jurisdiction. And we've had some opportunities to meet regionally, and it's really, really helped us to have a better understanding of all the capacity that can be done and unique ways and ways of working with federal partners. And so, just continuing that process, I think will be really, really helpful for the jurisdictions.
Yeah, you would probably be surprised, but probably my hardest work has been really kind of reintroducing what EHE means to our actual, already brown white providers and already brown white planning council has been my biggest fight around what does this new funding mean. And so I think that it would even be helpful to have some guidance around how, particularly on the CARE side, how does our Round White Part A dollars and these EHE dollars play a part and complement each other and work together?
I was actually going to say the same thing. My county is a great example of siloing. I mean, we're separate. We meet occasionally, but we don't accomplish much together. I think Dallas County is a great example of how the two fundings can be combined to really make a difference. So I would suggest the federal partners try and find a way to stop the siloing, or find a way for CDC and HRSA to work together to not tell people, well, you can work on prevent, but don't help people who need treatment. There's got to be a way you can combine it.
I'm putting on another hat as a EHE funded organization. In my organization, a small nonprofit, Southern Black Policy and Advocacy Network, in order for us to take advantage of our EHE funding, we have to take 5 funding categories in which we have to report on each one of those 5 categories. So the need to bring that together is so important, because it creates such an administrative burden to have one grant that you have to report 5 times on in a month. So that's definitely a challenge for new and smaller organizations.
Fenton, that's your EHE funding from the health department?
Correct.
Thank you so much to all of you. I have to say, it's a proud day to be a Floridian. I am really just... I am absolutely stunned by the challenges that you all face here. So really kudos to you for staying the course. I mean, the challenges with opt-out testing, our public-private partnerships that have occurred in Florida are almost on the brink of having state funding for our opt-out testing, and we've responded to the syndemics of hepatitis C and syphilis. Even so simply as having Cabenuva, having these amazing tools on your ADOP formulary, it's truly shocking to me. So I know there's an opportunity for public-private partnership there as well, and I saw that you went past the syringe exchange bill quite quickly, and that's really very close to my heart. I know that medical students can be mobilized as frontline people to try to make that happen. But I think overall, my question is just really, what role is the stigma playing in this epidemic here in Texas? Because we know that HIV criminalization continues to be an obstacle here. And I have not heard that much about substance use since I've been here in Texas. And being from a state where substance use is very much driving the epidemic, I'd like to know more about the barriers and that substance use is providing to being able to move HIV policy forward in the great state of Texas.
if I can just answer a few things to what you just said as a Texan, one of the, I think the biggest issues is that we don't talk about these things out loud enough here in Texas. Because when you talk about it, it makes these things real. And oftentimes in the state legislature and Republicans, they don't want to hear about that because then that means that they have to put dollars and funding towards things that they don't typically see communities that look like them that are affected by these things. And so unless there is you can show them that there is a population of white cisgendered men or white cisgendered women who are being affected mostly or disproportionately by these things, it's kind of hard, in my opinion, to see a change in that in that landscape. But also, we talked about what we saw really briefly is the sex education. There is no sex education in Texas. The last thing that I remember when I was in school 10 years ago was that it was abstinent-only education, and I'm pretty sure that's still just abstinent-only education in Texas. You don't go beyond that, and so to piggyback off of that, my question would be maybe for Rep. Jones and the others here, what can we do to help push past abstinent-only education to provide the tools and resources that folks need? Because I remember, I think PrEP came about publicly and it was passed to be used for a prevention mechanism in 2012. I graduated in 2013. There was a whole year where I could have gotten education around PrEP and could have gotten access to PrEP, but I didn't learn about it until, for me, unfortunately, it was too late.
And I'll invite one response to this because we're eating into
our
lunchtime. So, Benton, please.
Let me not interrupt lunch. I'll just say, partner with organizations that are pushing voter engagement and getting people out to the polls, because the only way that this is going to happen is replacing the leadership and replacing the people who are pushing these things, because alternatives to abortion has just been refunded. And so all the things that we fought against in the 90s are coming back. There are new pieces of legislation. So we can't even talk about drug users or people who utilize syringes, because the bigger populations that they're a part of are the ones that are actually under attack. So we really have to make sure that we are getting the right people in these offices. And then, two, the ability to help people have and understand how to move these conversations around state legislative bodies. Most people do not even understand the amount of power that state bodies have, and are oftentimes they get engaged too late. You can't come when the bills are already filed. You can't come when the things are already moving. You have to be a part of that process the entire time. So if there are any ways to, not necessarily, I know a lot of nonprofits and government entities can involve in direct lobbying, but there's so much education that's needed, like we see in Washington, D.C., where there are almost weekly visits on the Hill to change hearts and minds. That needs to happen and be replicated on the state level.
Thank you. Guillermo, please close us out.
Yes, thank you. I really want to say to Hope, Miranda, Dawn, and Jason, on behalf of PACHA, we want to say thank you to each of you, but please be a messengers to your colleagues that we are grateful for your work. I only have one request for you to do your very best in your counties to support small, micro, community-based organizations that are led by trans people or the people most affected by this epidemic. And I always say that we're going to end the epidemic through the South. That means we're going to follow you. Thank you.
And I really want to share with the PACHA members around the table, we have received a certificate from the State of Texas House of Representatives presented to the Presidential Advisory Council on HIV/AIDS on the occasion of the 80th council convening. On behalf of the constituents of the state of Texas, House District 147, and this is from Representative Yolanda Jones, commend your commitment and dedication to the quality of life for Black and Brown Americans living with HIV. Your fulfillment of your mission is worthy of respect and admiration. Thank you for your formulation of recommendations, appropriate plans, policies, programs, and strategies for the prevention and control of HIV. And so on behalf of Yolanda Jones on this day, she wants to congratulate and thank PACHA. For those members around the table who have pre-ordered lunch, please follow our local hosts, our health equity escorts, as I see. Follow them and they will take you to your pre-ordered lunch destination. For those of you who did not pre-order lunch, you are on your own. We will convene
right at 1 o'clock. So if everyone can be back in the room, we will begin after lunch on time.
Produced by the U.S. Department of Health and Human Services.